Hello, everyone, and welcome. I'm Danielle Hessler-Jones. I'm a co-director of SIREN, and it is my pleasure to welcome you here today to our SIREN Methods webinar on engaging communities and patient voices in social care research, where we're going to be hearing from our colleagues from the Health Experiences Research Network, or HERN, today. We at SIREN are committed to engaging community members and individuals who are experts through their lived experience in all of the work that we are doing. And we're continuing to reflect on ways that we can deepen and progress this work. And so I was really excited that earlier this year, I had the pleasure of joining colleagues from HERN to learn more about the work that they've been undertaking for many years to lift up patient voices. And today it's my pleasure to get to welcome them here so that others here can learn about the exciting work that they're doing, grounded in a methodology that they're going to tell us about, and so that we can all think about ways that this may connect more to the work that we're doing. On the next slide, I just want to, in gratitude, recognize our funder who makes all of this work possible for hosting these webinars. Our deep gratitude to the Robert Wood Johnson Foundation. And before we dive into the content, I have been tasked with the responsibility of sharing both the webinar logistics and just a couple of news about upcoming events. So first, this webinar is being recorded. I think this is the #1 question that we usually receive in our chat. So yes, the webinar is being recorded, and we will send a link to the recording to all the registered participants when it's available. We also welcome your questions. So please do use the Q&A function, not the chat function. So think in the bottom, when you have a question at any point during the session today, Q&A. And if you accidentally use the chat, don't worry, we'll redirect you. Next slide. I do want to just give a brief background for those of you who are new to SIREN. For those of you not familiar with us, SIREN stands for the Social Interventions Research and Evaluation Network. We're a research and dissemination center at the University of California, San Francisco. Our mission is to improve research on social and medical care integration by synthesizing and disseminating research, by convening stakeholders, and by conducting and catalyzing research. And we do have a few different ways to stay in touch with SIREN. So in addition to webinars like today, one of the best ways to keep up with us is to sign up for SIREN's monthly newsletter. So if you aren't already receiving that, it's chock full of awesome stuff. We've got a research roundup with highlights from social care research for the month, funding opportunities, policy and advocacy opportunities. So if you're not already hooked in with us, consider signing up at that link you see there at the bottom in yellow. Another way to connect with us in the near future is thinking about attending our next webinar. So our next webinar coming up is continuing on thinking about ways that we are engaging communities in social care research. And this one's very near and dear to my heart. We're going to be learning from SIREN's social care engagement grantees coming up next month on October 21st. And so these were SIREN grantee research community partnerships, 4 different community academic researcher partnerships that over the last 2 years have been carrying out projects aimed at strengthening community engagement and amplifying the voices of those with lived experience in social care research. So if you haven't already, there's a QR code there to consider registering. I really hope to see you there. And now, without further delay, I am thrilled to welcome our colleagues from the Health Experiences Research Network, or HERN. We have with us today Nancy Pandhi, Njeri Grevious, Kate Smith, and Rachel Grob. HERN is a nonprofit research group that seeks to bring patient voices to the American healthcare by leveraging the database of individual patients' experiences. And so it's a methodology that we're going to be learning more about today that lifts up and disseminates patient stories. And today we'll hear more from our panelists about this methodology for centering patient experiences, the impact that this can have in our work, as well as opportunities for where we can be considering this for social care research moving forward. So please join me in welcoming our panelists. It's now my pleasure to turn the virtual mic over to Njeri. Thank you so much again.
Hi, everyone. Thank you so much for joining. Allow me a brief moment so I can go ahead and share my screen with all of you. We are so excited to be here and also really appreciate the opportunity to get to know all of you and share some more insights on what's happening here at HERN. So, the title of our talk today is Leveraging Qualitative Research to Highlight Social Determinants of Health. And we want to really introduce who we are and our network and what we do. And I am going to briefly take this opportunity to kind of highlight who we are. My name is Njeri. You heard I'm joined here by Rachel, Nancy, and Kate. They will all take an opportunity soon to be able to share their experiences, their introductions, and their whys for why we do this work. But just by way of context, I wanted to start by just sharing a little bit about how we came to be as the Health Experiences Research Network. So we are actually part of a global movement, if you want to say that. So we are part of an international group of over 14 countries using similar health experiences methodology. And this methodology is the Health Experiences International methodology. And it was actually originated at Oxford in the UK. And so you can see from this little global map here, we have a lot of representation globally in England, in the UK, in Australia, in Asia, and then we in HERN are, really focused on the United States. And as the HERN network, we actually are a consortium of researchers and advocates at different institutions. And we'll definitely share more details about our website and who we are as we continue. So, founded in 2014, and it's amazing to say that because we've been almost over a decade in the making, we really are dedicated to elevating patient voices using this methodology that we just shared about that is being used at a global level. We are kind of very, very intentional about emphasizing deep narrative-based qualitative experiences that we extract through interviews. And our research is conducted throughout the US because, again, we're a consortium of folks from different parts of the US. And our main focus here is really kind of leveraging maximum variation sampling to capture as wide a range of lived experiences as possible. And we do that from a demographic perspective, a social perspective, a structural perspective, as much as possible. And you can see from our little graphic on the right here, our methodology is very rigorous, and it really does build on empathy to improve care quality in different ways. And our goal is to really have these stories that we're able to gather be available, so that way we can continue to have that connection between those we are researching and the research that we actually publish. And so the work that we do, because it is research focused and focuses on that methodology and the maximum variation sampling, we end up often complementing a lot of social determinants of health research. It is a qualitative methodology, and so we actually do a lot of analysis. You'll hear about kind of coding that we do in each of the different types of modules and deep research projects that we conduct and then publish that surface the lived realities of those who we are able to interview through this methodology and through this research. And so we actually go from getting some diverse perspectives through our sampling to synthesizing these stories across those different experiences and then amplifying them through dissemination. The way that we try to disseminate is through our website, but also there's other ways of dissemination that we've explored as well. But this kind of is core to our mission because a lot of the material that we end up publishing, producing from our research modules to the papers that we write is kind of put on our website, which is healthexperiencesUSA.org. And so you can actually go ahead and check that out. And here you can see our publicly accessible web content is organized thematically. And we show from each of our different types of research projects transcript excerpts, audio, and video clips. And we have about 8 modules on the site right now, as well as other products, which are catalyst films and pilots. And we'll talk about what these other products are shortly. And we have over 500,000 users to our website to date. And we have several 100,000 total sessions and counting. And so this is a living, breathing body of work. We are continuing to do research. We continue to add material to our site. We continue to disseminate. We continue to try to shape the conversation through the qualitative research that we perform. So one of the other types of products that we put on the site, in addition to our big bodies of research, which we call modules, we do a lot of these interviews and kind of share a lot of the themes that we see in each of the different types of health topics that we cover, from traumatic brain injury to breast cancer. We also have catalyst films, which are a shorter but more powerful film that is somewhat artistic in nature, but also aligns with our rigorous methodology and uses experience-based co-design in order to co-develop with patients who are part of our modules and who kind of work with us to be able to highlight what are the different complex and maybe underexplored issues within a module that can stimulate conversation, stimulate discussion, stimulate an additional look. And so an example of one of these films is the young adults' experiences with depression. It was a module that we did in 2015, as well as a catalyst film that we ended up publishing. And we also published a paper on our development of this catalyst film. And the idea is that it kind of challenges common assumptions about depression, who has it, and explores a whole bunch of different themes, some of them overlapping heavily with social determinants. And we'll talk about what that looks like through our modules shortly. And so when we think about all of this work that we do and the work that we are publishing, from the modules, the catalyst films, the research that we do, we are not just interviewing patients with a camcorder. What we do is very intentional, and it's rooted in this rigorous methodology, and it is co-produced. And so we really kind of anchor on that. And that's part of what draws me to HERN myself. And so part of what brings me to the Health Experiences Research Network is that I was actually a participant in the depression module in 2015. And through that experience, just sharing my story about experiencing depression, I realized, how powerful it was, the idea of storytelling, but also being able to share it in this way, and also kind of what insights were gathered from my experience as well as others. And it led me to kind of be joining the advisory board for that module, and then becoming an ambassador and helping with dissemination efforts. And then now I am on the steering committee for HERN, and I also have been working with SIREN as well. And so Danielle and others at the SIREN team have been very, very good friends and colleagues, and I was able to help advise the national research meeting at SIREN that helped happen earlier this year. And I've been exploring a lot of themes important to SIREN, especially when it comes to our SIREN grantees, who are exploring some really top of mind and important issues crucial to social determinants of health in that space. And so for me, given my journey, the work that I do in HERN, I really see as like a model for bidirectional engagement and community building, and kind of a way for us to also think about what are these social determinants, what do they mean, and what impact can they have. But again, that's one lens and one perspective from my experience at HERN, and I am now going to invite my colleagues to be able to share their experiences. And so I'll go through the order on my screen. Nancy, feel free to go ahead and share.
Yeah, so hi everybody. I'm Nancy Pandhi. I'm here at the University of New Mexico and have been really passionate about HERN from the beginning. And so for me, the reason for that is because of the storytelling aspect first. And so coming from a culture where storytelling is really how information, knowledge, those hidden ways of accessing sort of how you behave in the world was really critical. when this method came across, my sort of awareness, I immediately lit up because again, I saw, the way that trust and sort of access to healthcare could be really impacted among many other ways, and the importance of hearing stories, especially stories maybe that aren't as visible. So that's why I've loved HERN and been really passionate about this way of doing things.
Thank you so much, Nancy. Over to you, Rachel.
Hi, everybody. I'm Rachel Grob. I'm at the University of Wisconsin-Madison and passionate about HERN because I've always wanted to have an impact on the systems that affect not just healthcare, but also health. But being an advocate who relies only on one's own story and experience is, I think, a very shaky starting place. You need to have a method for understanding what is happening to other people with a vast different array of experiences. And this methodology is such a beautiful way of making sure that system change initiatives and efforts are grounded in the lived reality, systematically collected and rigorously analyzed of a very broad group of people, and therefore are more likely, if successful, to actually create positive change.
Thank you so much, Rachel. Over to you, Kate.
Hi, everybody. I am Kate Smith. I'm on faculty at the Johns Hopkins Bloomberg School of Public Health in Baltimore. And I'm a qualitative researcher, first and foremost, sociologist, and have been working in public health for a really long time, bringing qualitative and mixed methods work into public health. And this is just such a natural fit for a public health explicitly action-oriented application for rigorous qualitative research. So this is just really it was a great find for me of how to make my work so applicable. I really also appreciate the fact that the way that we do and disseminate our work and the centrality of video-based dissemination really keeps the perspectives of people that we look for in qualitative work connected to the people themselves. And it can be so much more powerful to hear directly from somebody talking about their experiences rather than just reading an extract on a page. So really love this approach.
Thank you so much. And so you can see that there's so many diverse ways in which we're kind of brought here to do this work at HERN. These are some of our motivations, and we have a whole team that we work with at each of our institutions. And, we also are drawn to it by various motivations. And so with that, we wanted to kind of talk to you a little bit more about what social determinants of health look like in practice when it comes to our main body of work, which is our modules. And so over to you, Rachel, to kick us off. Thank you.
You're muted, Rachel.
There we go. Let's get a little bit more specific on the next slide, and Njeri, about what our content is. When we do these in-depth interviews that Njeri referred to, we are talking about people's lives in general, not just their very specific health issue or their health care experiences. So we are in the context of health as broadly defined as possible, and focused a lot on the context within which their health experiences, their illness experiences, and their disease experiences occur. In terms of really specific content that really is in all of our modules, you'll see here on some of these bullets, some of those highlighted. We focus on work settings and educational settings and how management in the household, living with others and within your family context are affected. We talk about housing and transportation issues and hear people's experiences with those. We hear about how bias and discrimination impact health and healthcare, as well as how support and community affect it. We hear about people's self-advocacy and their own system advocacy work, and also about the continuous learning that often occurs over the trajectory of an illness or disease course or experience. We also probe specifically on and hear a lot about insurance and financial issues. So I'm going to spend a little time highlighting so that you can get a clearer and more concrete view of HERN's work around social determinants. We're going to highlight content from our breast cancer module, and what we heard from some of our participants, a subset around the insurance and financial issues. So let's go on to the next slide, where I will stop talking and we will start hearing those voices Kate was referencing. This is a clip that is also on our website among thousands of other clips. And this is Carrie talking about how, even though she was insured, the co-payments related to her treatment resulted in bankruptcy. Let's hear Carrie.
Well, when I worked retail, it was a little less comprehensive. So we basically were responsible for about 20% because we were considered out of network. That was a lot. And also there was a recession, and there was a little, just a lot going on. And I was hourly, so then when I did take out for FMLA, I mean, my job was safe, but I had no income. And my husband's a private contractor, and again, it was a recession, and so he was working in manufacturing, and that wasn't going great. And like I said, 20%, we were responsible for 20%. We did work with the hospital on their community care program, and got some grants and some of those things forgiven. But in the end, we had to file bankruptcy or we were going to lose our house. We had to coach our kids not to pick up the phone when the debt collectors were calling. It was an eye-opening and humbling experience to go from a solidly middle-class family, and then just through the illness and the recession, and it's kind of a perfect storm.
Beautiful. Next up is Kawana talking about the need to keep a job because we have employment-related insurance in this country.
I was like, well, I need insurance, so I gotta keep working, even if it's 4 hours. I gotta keep working so I can pay for the insurance. I didn't know that I had other options. It pretty much was vaguely, paid family leave, 12 weeks, but then what? Because that, and time just goes by, and at this point, I was already, I was in the midst of the first most draining chemo, but I would just have to push myself for at least 4 hours. And I didn't know the HR person well enough to advocate for myself on that end, as far as like, I need another choice. I wanted something that was gonna say, okay, you can stop. Or I wanted someone from the beginning probably to advise me, listen, it's probably in your better interest because things are gonna get harder, that you might wanna consider ABC. Right. But I didn't know any better. Yeah. So I just pushed myself as much and as far as I possibly could.
Next, we'll hear Maria de los Angeles talking about both kind of getting the diagnosis, thinking about insurance issues, and ultimately being rejected from the first clinic she went to because she was uninsured. This is in Spanish, so if you don't speak or understand Spanish, you might want to read the English translation on the slide.
Entonces, esperé unas semanas para los resultados y me llaman que pues que querían hablar conmigo en persona. Y pues me dijeron que era cáncer. Sí fue duro. Era preocupante porque no teníamos los medios, el dinero. Y uno como hispano o latino, pues se preocupa, ¿no? Que tal vez que el seguro médico, buscamos información, nos mandaron a una clínica donde, por cierto, por no tener seguro, me rechazaron la primera cita.
And finally, here's Katrina, who herself worked for many, many decades as a nurse, so knows the healthcare system as a provider, and now as a person with metastatic breast cancer is worrying about what it means to be on Medicaid.
I don't know if they do them different or not. You know, I just sometimes you hear, oh, they on Medicaid. You know, I don't know what that means. It's supposed to be a different type of care. You know, so I just, even if you visit hospital, you know, you can just overhear stuff and be like, oh, yeah, they on Medicaid. I just, do it matters? Do Blue Cross matters from them, or do they go first? Do they put Medicaid last? I just be really want to know. I just really be want to ask. I'm just, it makes me upset because I done been on both sides and it don't feel good on Medicaid. And sometimes I can tell a difference. Like I might be last. Like more people have been, like if I've been there sitting, I'll go ask, you know, when is my name being called? I was here about 30 minutes ago, and this person, and then they tell me some whatever.
Beautiful. This is a graphic. I don't expect you to read it at all, but I just wanted to highlight another aspect of our work within which Njeri also mentioned, which is publishing in the peer-reviewed literature. So an updated version of this is forthcoming in a paper where we're highlighting these zones of conflict. If you just look at that middle row with the little conflagrations in it, between the aspirations, in this case, of a particular aspect of medicine, precision medicine, and the practices of health insurance. So those clips are part of a body of work which helps us to show these more systemic social determinant impacts on people's experiences with health and healthcare, and publications like the one cited here, which is forthcoming in the Journal of Health Politics, Policy, and Law. Finally, on this last slide before we turn it over to Nancy, just want to encourage folks to visit our website at healthexperiencesUSA.org and to check out, for example, the Gulf War module, the traumatic brain injury module, and the multiple sclerosis module, where you'll see additional aspects of social determinants highlighted as indicated on this slide. Back to you, Njeri.
Thank you. Handing it over to Nancy. Ooh, go ahead.
Great. So I will be talking about some of the applications of this work, and in particular, the aspect of education, where we've done additional work to actually rigorously test the impact of seeing these videos. Next slide. So you heard about our depression module, and this was really our first one in our country here. And so after completing the module, we wanted to see how it would work to have medical students exposed to this kind of a curriculum that was based on the modules themselves. And so we created a curriculum which was self-directed, where people either had the opportunity to go ahead and do that, and the traditional curriculum, which is a case-based approach to learning about depression, or they just did the case-based approach for depression. So these were third-year medical students. They were just sort of understanding in more in depth how to work with patients at that point in their care. And what we found was pretty interesting and kind of validated what we were thinking, which was that students who actually were exposed to this curriculum had a pretty similar response to seeing these patients on video compared to the ones that they would see in their clinical settings. And then they also reported greater decrease in their own stigma towards people with depression compared to those in control. And so that really helped us understand, and what we were expecting is that the empathy and the understanding that is created by exposed to these lived experiences has a lot of potential. Lastly, a significant piece was understanding that their own concepts, sometimes you learn things as one size fits all, but through these kinds of exposure to different people's experiences, you actually are able to get some takeaways about how heterogeneous that experience might be. Next slide. So after doing that work, we have done this in different groups of learners as well. So here in New Mexico, we continue with doing this work with interprofessional students coming from different clinical backgrounds. And then I wanted to really feature the work that's being done with the residents. And in this material, I will say, I just want to draw the attention to the acknowledgement at the bottom. This, what I'm displaying was very much developed and displayed, is being displayed with permission by our team of leaders of graduate medical education, Dr. Zaragon Salas, and also Dr. Suman Paul, who is the one who actually learned about HERN and said, oh, this would be a great way to bring this work into our curriculum. So what we do here is that on the very first day for all residents at the University of New Mexico, we offer a case-based workshop that's illustrated by lived experience vignettes that are drawn from the website. Similar to these other ways that we've done it, everyone learns about the cases and watches the videos as a group, but then they go into smaller groups where they actually have facilitated discussions. And in the next slide, I'm going to walk you through that in a little bit more detail with one of the cases that's done. Okay, so one of the cases here is from the pilot that's up on the website about experiences of living kidney donation. And so I'm just going to read the way it would be if you were in that audience of learners. So Zoe lives in Deming, New Mexico, and you can see on the map that's about 3.5 hours away from the tertiary care center here in Albuquerque. And her daughter, unfortunately, had developed kidney failure after a routine strep throat infection. Sophia was approved for a kidney transplant, but few family members were available to test for donor eligibility. Sophia's biological father has had no contact with the family for several years, and Zoe, the mom, has no other children. Luckily, Zoe was found to be a donor match. She was initially elated that her ability to be a donor would spare her daughter's months of dialysis. Next slide. Okay, so then we're going to hear from Zoe directly.
These doctor visits, the hospital that we did this at was 4 hours away, about 3.5, 4 hours away. So taking her to these visits, taking her to all these classes, getting all our testing done, it was kind of hard doing it, you know, on my own. So I'm very thankful that they did educate us, but it was draining. It was draining to, you know, travel so much. It was like probably 4 or 5 times a month that we'd have to go up there and see her doctors, get her dialysis, and then do those classes, and then get a hotel, and then travel back the next day. It was a long process, and it was very, very hard and emotional. The only thing that really I feel I wish was improved. Like I said, my daughter's kidneys were failing, and they said, you know, if we can get our kidney transplant date soon, she would never have to have gone to dialysis. But because my testing process took so long, she did have to do 7 months of dialysis, and I wish that wouldn't have happened. And it's just trying to get into those appointments. I mean, if I was already cleared and they said, yes, you are a match, I feel like that should be rush priority. Okay, so the next day or the next, sometime this week, let's get you in and get all your testing done in one day, get everything knocked out so we can get this done as soon as possible. But that wasn't the case. I know my mammogram took a long time. From the time they told me that I was a match for my daughter, it was probably 2.5 months before I could get scheduled for a mammogram.
So then in the discussion, we go a little further and we show the kinds of appointments that are required before you get a kidney donation. So won't go through the whole list, but you can see that there's needs for primary care, routine preventive screening appointments, lab appointments, dental care, and if they find something, they need to do to address that need before it, and then appointments with the specialists as well, in addition to what you heard in the video, which is also the whole education piece about donating your kidney or receiving a kidney. Next slide. So here's the questions that we have the residents think about. When a patient is scheduled for several appointments at a tertiary center, what assumptions are we making about the patient for them to be able to adhere to the care plan? And this really opens up their eyes, right? Where they might at the tertiary care center being like, oh yeah, we'll see you back and do these things, but really giving a chance to think through the social determinants and a really rich discussion about all those potential barriers that could occur between when people actually have the appointment scheduled and what's needed to be done to make that happen. Then we often do something that's an application. So what if Zoe and Sophia were from Gallup and had Indian Health Service insurance? So here in New Mexico, as in many other states, Indian Health Service is the way that Native populations can access care. But of course, there's structural determinants there as well. For example, running out of specialty care referrals towards the end of the year, which could impact care. So this is an opportunity to introduce those ideas. And I will point out, putting this with residents, many who are not part of New Mexico, this can be new information for them and really critical for them to understand in order to care for our patients here at the University of New Mexico. And then we really think it's important, it can feel a little discouraging in terms of these big systemic problems, but how do you actually engage people to start thinking about the solutions for the future? So we asked this third question about, their ideas of redesigning care. And the hope is that, and in particular, rural, because that's important to our state. And our hope is that, then they're starting to see that they can actually be empowered to be part of the solutions for the future. Next slide. We also find that it's important to do a closing just so that people understand what happened. And so here you can see with Sophia, after that dialysis, she did get that kidney transplant surgery from her mother. Her mom did share this. It was hard for her to be in the same hospital room with her daughter during the recovery period because she didn't want her daughter to see her in her own pain as her daughter herself was, focusing on her own recovery. But afterwards, the hospital did coordinate a hotel and help them in the next month with all those appointments that they needed to make. And luckily, Sophia has not needed to have dialysis. She's had a successful transplant thus far. Next slide. So back to you, Njeri. And Kate. Actually.
Yep.
Yeah.
Go ahead, Kate.
Sure. Thanks so much. So now you know a little bit more about what HERN is and what we do and why we do it. And the reason that we're here today is because we're looking to make connections with individuals like you, organizations like SIREN, to hopefully increase the impact of the HERN initiative and to help us figure out sort of important ways forward. And there's many ways that we can do this. So next slide, please, Njeri. And here are some of the ways that we can do this. So the first is, as Nancy's just talked about, there are ways that our data can be used in training and clinical education curricula. We can have HERN videos and transcripts embedded in medical, public health, or social work curricula. We can leverage our HERN training, which I'll talk to you about in just a moment, for teams that are looking to build capacity in qualitative patient-led methods. We can develop faculty, we can do faculty development or continuing education programs around lived experience data. And we can use patient voice clips to train providers in empathy and trauma-informed communication. So these are things we've done in the past, and we are looking to partner on similar things in the future. We also have lots of opportunities for research partnerships. So we are looking for opportunities to use our rich, rigorously collected narrative data sets for secondary analysis. We've got more data than our collective will ever be fully able to utilize and explore, and particularly in relation to SIREN around the social determinants of health lenses, such as exploring structural themes, including access, insurance, stigma, as well as other social determinants that so shape personal experiences. And we also would be looking to co-develop grant proposals for future work and evaluation plans using our data as qualitative evidence. And then finally, just another way to think about utilization of the work that we've already done is in relation to development of toolkits and other dissemination activities. Our work is already cited in several different national toolkits and research guides, but we'd really love to expand that work. And we're looking to partner with others to co-create resources that highlight community voices and real-life barriers to optimal patient experiences in healthcare. So next slide, please. So finally, just drawing your attention to our training opportunity. We do training in the HERN methods about once a year. It's hosted by our team, our colleagues at University of New Mexico. It's an intensive few days learning about this method and working with all of us to understand it better and hopefully get you thinking about how you might do similar things. So if you are potentially interested in this, please, there are some information here, and we would be very happy to provide information on our training in future follow-up. And I think that's it from us. So thank you so much for listening.
Thank you so much, Kate. Thank you, Nancy. Thank you, Rachel. We are all here to be able to stay as key resources and point contacts to all things HERN and health experiences research. We do have an Instagram, please follow us, but also we have a QR code here for our website. Please check out our website, healthexperiencesusa.org. And with that, I will pass it back to Danielle and the SIREN team as we open up for discussion.
Fantastic. Thank you all so much for that fabulous presentation. It's amazing to get to hear more about your work, and especially bringing those specific videos so that we can all be there, right there with you. I am going to encourage folks to start to put in their questions in the Q&A, and I see a few rolling in, but I'm gonna sneak in a question of my own to kick things off. Near the beginning, when you were describing the methodology, I heard you speak about the partnership. That it's not just an interview where you swoop in and then swoop out, but rather a partnership. Could you tell us a little bit more about the methodology and how the individual who's engaging and sharing these details with you, what role they have after the video stops rolling?
I can go first and then invite others to comment. It's a really good question, and it's not the same for everyone. Some people want to engage in the interview, and it is a gift of their confidences, their narrative, a description of their experience, and they kind of want to be done. Then there are people like Njeri, on the other hand, who sort of start out in one way and really become like hooked and want to advise, want to participate in publication opportunities, actively stay in touch with the team. And so definitely a broad range. What I will say apropos of the methodology itself is that we do operate with the assumption that one's story always belongs to oneself. And so we do ask people to sign a form saying how they would like us to use it. Can we on the website share their text, their video, their audio, none of the above? Do they want to redact parts of what they said because that part they don't want to share publicly, but the rest is okay? And they can always, always change their mind and either share more and get involved more, which is sort of the story that Njeri told, or remove their content if they're no longer comfortable. That has not happened a lot in the United States, but we did have one person who felt that as their life developed and their career developed in a certain way, they no longer wanted to be represented in the particular module they were on, and we just removed all of their content. So no matter how much you may want to go beyond the very important act of telling yourself your story and telling it out loud and then sharing it at least with your interviewer, those sorts of relational aspects of the methodology are a commitment between every researcher on every team and every participant in every study. And I will leave it to others to add in other thoughts.
I might quickly just add the advisory board aspect. So all these projects are done with an advisory board, and there's, both people with lived experiences, clinical experts, and also experts from kind of the advocacy or other spaces as well. So we really try to get that balanced perspective in the advisory space, and they are consulted throughout the project, even in the early design stages as well, if ideally.
Fantastic. And actually, Nancy, that's great because that's leading into another question from Sarah from our audience of can the methodology be used to better facilitate patient advisory groups? So if you could expand on the advisory group role and also kind of, how the methodology intersects with it and what you think about in terms of facilitating the patient advisory groups.
So maybe I can jump in there and say that the methodology is, the sort of primary methodology is explicitly to hear from people, and usually it is a one-on-one interview, or in some instances, there'll actually be a patient and somebody that is sort of intimately involved in their care, and they sort of in the MS module, for example, we had a few of those instances where there was a dyad. So that's in the sort of the central methodology, that's sort of core there. But actually, in relation to patient advisory groups and other ways of sort of thinking about stakeholders in improving care, the data that we generate here can be wonderful vignette and material to sort of engage to open up discussions and sort of think through issues and in ways that can be really profound and powerful. So I think the data that are generated through this method can absolutely be used to facilitate group discussion around an issue. But the method is intended to be a narrative method, one person's story, not a group sort of discussion of an issue, more like a focus group would be. Hopefully that answers the question.
Thank you. Thank you. And then another question from Taylor is, do you train or coach people on how to share their story before they share?
I can jump in there and then maybe Rachel. So very little. I mean, what we do is spend a lot of time, as much time as people want and need, explaining to them who we are, what the method is for, and why we're coming to them, and why we'd like to spend time hearing from them. But then after that, actually, our initial stance is saying to people, tell me your story. Tell me what's important for you to know. So there really isn't, we explicitly do not have an idea of this is how we want you to tell your story. And so we, sometimes for people, that means that the first 40 minutes or so of the time we spent with them, you'll hear very little from us because they have a story that they want to tell us in a particular way. And then we'll follow up after that and ask them to expand on some things, clarify. But there's other instances where people will tell us just a little bit and then need more prompts to sort of help them feel comfortable telling us what they've experienced.
Yeah, I'll just add that we've had some, I think, wonderful and healthy debates in our learning community, which is another dimension of HERN, because we're always trying to get better at what we do. And here, since we're a national network, how the team at UNM may be coping with a problem that's coming up in Wisconsin, and then the Hopkins team will weigh in. So I think that our desire is for people to feel comfortable with us sharing video, audio, or text clips. And if that is somebody who wants to like dress up for the camera, that's fine. But we're also not going to suggest to them that they should be appearing necessarily a certain way, because it's not about having some like look on our website. It is about trying to create a platform where, though, of course, we are we're touching the data, we're interpreting it, our reflexivity as researchers is always in play, and we understand that we're involved and that in some way we're also co-producing the story by being the listener. But what Kate said earlier about trying in a way to sort of get out of the way and create a platform where people's stories can be heard by other people. Again, the platform is really primarily used by other people with similar experiences and their families, although it's also used for all these other applications. So we want people to show up in the way that they are going to feel comfortable showing up, not in the way that a communications department or a PR department would want to coach their spokespeople to show up, which is a very different kind of endeavor.
And if I may add there, having had lived experience being a participant in one of the modules, but also being on advisory boards, helping with dissemination and ambassador stuff, one of the things that I've, experienced is that when I was part of the depression module, I actually decided to, as I was reviewing my own content, realize that I wanted to be anonymous. And part of that was in response to stigma that I was struggling with at that time and that I'm very aware of. And so it was one of those things where I had the freedom to decide how I wanted to show up. And at that time, that is how I wanted to show up. And so we give a lot of our participants the agency to decide what showing up means to them. And we pay attention to that, but we also coach ourselves. And so another part of our learning network and also our trainings has been also coaching. What is it like to actually intentionally kind of conduct these interviews in a way that respects the participant that we're interviewing, but also kind of stays true and rigorous to our methodology, while also kind of maintaining a healthy boundary in a way that we can really truly kind of have a healthy co-design collaboration in that way. So that often does come up, and I just wanted to add that too.
Fantastic. We also have a few questions from the audience around impacts. So so one question that around if there's any examples you can share or hopes that you have for the future of how your work can be used to advocate for policy and relatedly systems change.
Yeah, I can take that a little bit. So, we do have some examples of systems change. Like, with the kidney project, we actually had the system changed here, based on these stories, the way it actually delivers a particular aspect of care in terms of coordination and complete shift of the clinical service when they heard the patient experience of that. So, it's one example, but of course, I think there's just that opportunity, right? If you get the right folks in the table who are either the decision makers or can advocate to the decision makers based on these stories and they ring true for them, this can be a powerful tool. So we're always looking for additional examples. So if you use this, please let us know in those settings. Policy has been sort of an aspirational piece, and I'd invite my other colleagues as well if they want to jump in there. In the UK, where this method is used, it is actually used as a more rigorous way in the parliamentary setting in terms of like, we're not just focusing on one story or narrative, but this is what's true across many people's experiences, and it's actually used more formally. But I don't know if anyone else wants to jump in.
Yeah, I think the analogy to the UK is useful. Although we're a decade old, we're sort of babies compared to the UK, who really are wonderful exemplars. I'll add, in terms of direct impact, we have done some work in our node at the University of Wisconsin on experiences with long COVID and been piloting that in a clinical setting to see if primary care teams hearing directly from patients about what's helpful to them with a novel clinical illness for which there are not many proven sort of medical interventions at this point, how to help get on disability, how to do documentation, how to stay in touch around the evolving knowledge base. And we've seen some impact in terms of the sense of self-efficacy and confidence that clinical teams have after being exposed to this kind of tool. We're right now working on a project in a rare disease area to try to have an impact. We haven't done this yet, but we're funded to do it, to have an impact on insurance practices and coverage, particularly around durable medical equipment, which is a huge need for this particular subpopulation. So we've got some things in the hopper as well.
Fantastic. I think we have time probably for one, thinking in one final question here. There's been some great active dialogue in the Q&A around how does this differ from what we think of as like a typical qualitative interview and typical qualitative research. And Kate, you had already shared that one way it differs is in the intentional prioritization of that direct dissemination. And I just wanted to give a chance for the whole panel to share if you see any other key ways that you see this as distinct for the methodology.
I can say, expand that a little bit and say that as we developed our network and thought about the sort of principles and philosophies that would hold us together as people that are doing HERN work, there are things such as the involvement of and partnership with stakeholder groups, people with lived experience, right from the origin of this, which much but not all qualitative work does. There is also the scale of the qualitative work. So, for something to be considered to be a full module, it needs to be sufficiently in depth in terms of the experiences included. So we talk about at least 30 interviews, up to 50, with an idea of maximum variation sampling as a key goal. And we have mechanisms to ensure that we are sticking to those principles. So it's not necessarily that there are ways in which this is distinct from qualitative research, but it is a particular type of action-focused qualitative research that is always open for some developments and new innovation, but that is explicitly, we are also working to make sure that we all understand how we do work in a way that sort of is similar enough that people, that we as a network, but also people coming to us from outside can understand sort of the nature of HERN work.
Fantastic. Well, with that, I want to thank you all so much again for joining us today, for sharing your amazing work. And thank you all to our audience for not only showing up, for engaging here actively. I see lots of interest here on following up, on looking at those videos, on reaching out for collaborations. We will be sharing out a copy of the slides and the video for following this webinar in the next couple of days. So please do look out for that. And we thank you all for your engagement today.